We shall now proceed to the last round of presentations of SLCTRIMS 2026 with the case presentations. May I invite today's panel, Professor Owen Flanagan, Professor Hans-Peter Hartung, Dr. Bimsara Senanayaka, and Dr. Arjuna Fernando. Please take your seats in the first row. Please take your seats in the first row. Our first presenter for the day is Dr. Pramit Ruwan Patirana, SR in Neurology, Institute of Neurology, National Hospital of Sri Lanka. Over to you.
Good afternoon. Let me start my case. This is about a 50-year-old Sri Lankan male who presented to us initially in June 2024 with progressive bilateral lower limb weakness and bladder bowel involvement, which developed over 2 days. Now, this patient was a patient diagnosed with diabetes, hypertension, dyslipidemia. There was a past history of ischemic stroke, but with complete recovery. His metabolic conditions were very much under control. So, let me walk you through the history of presenting complaint. 2 weeks before the presentation, he developed an upper respiratory tract infection, which is quite unremarkable. And then, on one particular day, he noted that he was developing a progressive bilateral lower limb numbness and weakness over 2 days, which was associated with urinary retention and constipation. His upper limbs were normal. He did not have any trauma or any similar episodes previously. His vision had always been normal. On examination, he was conscious and rational. His cranial nerves were normal. And on examination, there was a paraparesis with a power 0 out of 5 bilaterally. It was hypotonic and areflexic, and the plantars were flexor. But there was a sensory level at T8. Because of that, we localized this to the thoracic spine. We imaged and we found that there was a long segment transverse myelitis extending from the 6th thoracic segment to conus medullaris. In fact, it was extending into the cauda equina as well. I'd like to rerun the video where you can see the cross sections from the thoracic, from the T6 segment, the lesion with spinal cord edema extending all the way up to the conus and into the cauda. With that MRI spine, we did some basic investigations to identify the etiology. The hematological investigations were markedly unremarkable. ESR CRP was normal. And in the cerebrospinal fluid analysis, we found a high protein, and it was cellular with predominant lymphocytic reaction and a few polymorphs. So we considered this clinically as a transverse myelitis, treated the patient with 5 days of IV methylprednisolone, and there was not much of an improvement. Therefore, we went ahead with 5 cycles of therapeutic plasma exchange. But unfortunately, the improvement was not very remarkable. In the meantime, parallelly, we were evaluating for the cause. We did an infectious screen. The infective causes were negative. We wanted to look for the autoantibodies, but this is not the best time for our country. We were just recovering from an economic crisis. So we could not afford those antibodies at that time. And we went ahead with a CT chest abdomen pelvis to look at a paraneoplastic cause, at which point we noted multiple mediastinal lymph nodes. CSF cytology did not reveal any malignant cell infiltration. Ladies and gentlemen, this is a CT chest of this patient, and you might appreciate there were paratracheal, and this is a parabronchial lymph node which I have pointed to. Being from Sri Lanka, we considered tuberculosis high on the cards, but we considered sarcoidosis as well. So we went ahead with further testing. We arranged a tuberculin skin test. We planned for a mediastinal lymph node biopsy. We did the serum angiotensin converting enzyme levels, serum calcium, and Because we could not find any other evidence of tuberculosis, out of desperation, we went ahead with a bone marrow for TB culture. Pending these investigations, we started the patient on tuberculosis, anti-tuberculous therapy because tuberculosis is quite rampant in this part of the world. And the outcomes of central nervous system tuberculosis is quite poor. We started the patient on individual drugs and was started on inward rehabilitation. By which point, we had the results of the investigations. Tuberculin skin test was negative. The mediastinal lymph node biopsy revealed non-caseating granuloma with epithelioid cells, and the rest of the investigation was negative. Although in tuberculosis, we quite often see caseating or necrotizing granuloma because of the epidemiological risk factors and the poor outcome of the disease. We ultimately concluded that this could be a spinal intramedullary tuberculosis because the evidence of an intramedullary lesion as well as a granulomatous lesion in the lungs, we continued the antituberculous therapy. So this is how the disease progressed, and this is a serial CSF analysis that I'm going to present you. On presentation, it was predominantly a lymphocytic CSF, and you might note a sugar drop, which had disappeared by July 2024, and that is the next month before we actually started anti-TB therapy. We wanted to reconfirm our diagnosis, at which point we sent all the investigations for TB PCR, all of which came negative, including the TB culture. However, empirically, we started antituberculous therapy, and at the end of 2 months, we routinely do another CSF analysis to see whether we have adequately treated the tuberculosis. And you might note that the lymphocytic reaction had disappeared, and the sugar drop has also disappeared. So in addition to antituberculous therapy, we usually treat these patients with a tapering course of steroids to reduce or to mitigate the immune reconstitution syndrome we commonly see with tuberculosis. So we continued antituberculous therapy for 1 year, and at the end of 1 year, we readmitted for assessment to see whether we are fit to stop antituberculous therapy. So when we reassessed this patient, to our surprise, the patient was still paraparetic with a power 0 out of 5. Still, he was flaccid and areflexic. So this was involving not just the cord, but conus cauda with maybe an anterior horn cell involvement like a flaccid myelitis. But because there was a sensory level, and he had lost his bladder and bowel control. Because of this poor lack of improvement, we revised our diagnosis, and we once again reconsidered whether this could be an immune or inflammatory myelitis. Now, sarcoidosis was once again brought up into the diagnosis, but we thought at least initially we had treated this patient with high-dose steroids, and we had continued steroids for a certain duration, so we expected some sort of improvement if it was sarcoid. Still, we once again thought of that, and we restarted our immunotherapy. We wanted to look at what has happened to the mediastinal lymph node, so we planned a repeat imaging, and we imaged the spine once again. And once again, to our surprise, we found that the spinal cord has atrophied completely. And this could be another reason why the patient remained flaccid at the end of 1 year of a myelopathy. So this is a comparison of the spinal cord at June 2024 and September 2025. So you see the edematous spinal cord, the edema has disappeared and it has become a thin string due to atrophy. The chest CT also revealed that the initial lymph nodes which were prominent in the mediastinum had also reduced in size into sub-centimeter level. By this time, we could redo our serologist tests, and we tested for AQP4 and MOG antibodies. This was using a fixed cell-based assay, and that was negative. We once again evaluated for sarcoid. Once again, all of the investigations, including the ACE level, calciums, and chest CT, which I showed earlier, did not reveal any evidence of a peripheral sarcoidosis. Ladies and gentlemen, this is the history back in a single timeline. So at present, the patient is currently on immunotherapy, thinking this could have been a missed NMOSD. And as for why the serology was negative, we attributed it could be due because of the delayed testing, or maybe the we were using not the best assay, and maybe the effect of plasma exchange. However, at this stage, at this point, the patient still remains with a paraparetic, and we, as for the etiological diagnosis, we are still not sure as to what is happening. And I would like to emphasize that the patient did not develop any new symptoms or any new complications over the last 1 year. Thank you.
Thank you very much, Pramit, for that presentation. I would like to ask Professor Flanagan with regards to this case. Now, I think at the very onset, the MRI you showed, I was wondering whether there was a bright spotty lesion there. So anyway, so the other issue was the lymph node biopsy, which showed non-caseating granuloma, and he was treated as for sarcoidosis with no response. And so I would like to know your...
Yeah, great presentation, complicated case, I think. You know, one thing that I sometimes look at on the acute MRI is the enhancement pattern. I don't know, I don't know if you had images of that there, but sometimes if you see dorsal subpial enhancement or the trident sign or things that can help you, or if you see a ring. The other thing is sometimes there can be some dilation of the central canal, or you'll see that when the cord is swollen, and that can kind of mimic a bright spotty lesion. But sometimes we see it as just a potential space, and then when the cord swells with any cause of myelitis, it lights up, so that it could be that also as an alternative, given the aquaporin 4 is negative. Yeah, I agree with you that it kind of, the acute flaccid myelitis is a possibility. I don't know the organisms in the region that can cause it, like West Nile or enterovirus or those kind of things, so they would be possibilities. It's unfortunate that there's been no improvement. I'm trying to think other things, I suppose. I didn't hear there was anything on the brain MRI or optic nerve exam for any evidence of any other regions involved.
Yeah, thank you, sir. So in the contrast enhancement, there was no subpile enhancement or contrast imaging or a trident sign that we could appreciate. Brain MRI was normal. We did the OCTs and VEPs. They were also normal, sir. So this was an isolated event, and there was no further any other clinical syndromes at which we could identify.
And there was no contrast enhancement at all, or it was there was some enhancement, but it wasn't in a particular pattern? Do you know?
In the brain, of course, there was no contrast enhancement. In the spine, these lesions were enhancing.
It was enhancing. Okay.
No, I'm sorry, we did not. Sir. Because it was a long lesion and the brain MRI was negative, we didn't consider.
Is schistosomiasis in this region of the world, or schistosoma? As an infectious cause, it's a parasitic cause.
Well, I have not come across, but I'm very junior, so.
No, it's a cause of long myelitis, mostly in Africa, I think, sub-Saharan Africa, but it's another one that can cause more of a thoracolumbar myelitis, and sometimes there's more eosinophils on the sample.
So as for the CSF, do you know, if for an infect, like a West Nile virus, do you expect this sugar drop, and do you think this could be due to sarcoidosis or?
It's hard to know. I think any condition that can have meningeal involvement or leptomeningeal involvement, you can get a little bit of a sugar drop. I don't know what the percent, how low it is there. It's harder when the patient is diabetic and their sugar is up. It's a little bit harder to interpret, so I don't know how much I would read into that as much. Yeah. I don't know how specific it is, you know, for any of these things. A little bit unusual for sarcoid when it presents with a long lesion. It's a bit unusual to be paraplegic that quickly. A lot of times they can get a long lesion and it can come on quickly, but it's a little bit more severe than we would see. Often we'd see they'd be still walking or they would have some preserved strength, so that's a bit unusual, yeah.
Do you see cord atrophy in sarcoidosis?
We have seen it, but usually it's more with a patient where there's a long delay to the diagnosis and it's more prolonged rather than rapidly accumulating that quick.
Thank you, sir.
Thank you, Dr. Pramitha, for that excellent presentation. And next up, I invite Dr. Sujani Suresh Kumar, SR in Neurology, Institute of Neurology, National Hospital of Sri Lanka. Over to you, ma'am.
Good afternoon, respected panel, ladies and gentlemen. This case is a wolf in white matter. So our patient is a 16-year-old girl from Central Province, and she was transferred to us from a local hospital after having been managed there in the ICU for 1.5 months for status epilepticus. So when she came to us, she had ongoing seizures, altered consciousness, and quadriparesis. She had been well until 1 year and 3 months before this admission, which was in January 2024, when she had developed right lower limb weakness. However, since then, she has lost to follow-up and has been on traditional treatment. This is how she came to us, bedridden, on a tracheostomy tube, NG tube, and Foley's catheter. She was having a seizure, posturing with increased tonicity, horizontal eye movements, increased heart rate, and rapid breathing. What actually happened was in January 2024, she has developed bilateral painless blurring of vision, which was of acute onset, with right upper and lower limb weakness and imbalance. She didn't have any numbness or her consciousness was normal, and at the time she was admitted in a neurology ward for 16 days. She had undergone an MRI at that time, which was reported as a leukodystrophy. So there were bilaterally symmetrical posterior predominant white matter changes and bilateral middle cerebellar peduncle hyperintensities. However, she was counseled about the poor prognosis of a leukodystrophy, and she had undergone treatment at Ayurvedic hospital since then. Following that, her vision and ambulation completely improved back to the baseline. 8 months later, in August 2024, she has had a recurrence of bilateral blurring of vision, which once again spontaneously improved. In October 2024, she then developed difficulty in holding objects with the right hand once again, right lower limb weakness, and imbalance on walking. However, this time it didn't come back to the baseline, but rather it has been progressive. She went on to develop involvement of the left side and had restricted mobility such that she was only able to walk 10 steps, and it progressed over the subsequent months such that she became bedbound, and when she developed seizures was when she presented to the hospital again, after which she was transferred. So you can see that initially she had 2 episodes with the return back to the baseline, and after the 3rd episode, she's had a progressive type of illness. She didn't have any constitutional symptoms and there was no psychosis. Systemic review was normal. She was a vegetarian and her parents were of consanguineous marriage. On examination, her GCS was 8 plus T, E4, VT for tracheostomy, and M4. So she had an increased tone of all 4 limbs. Power was 0/5 and the reflexes were brisk. Plantars were bilaterally upgoing. She had bilateral optic atrophy also. Her basic investigations were all normal. ANA was 1:80, nuclear fine speckled, and her visual evoked potential showed delayed latencies. Nerve conduction study and electromyography was normal. Her EEG showed a generalized slowing suggestive of an encephalopathy. MRI brain, which was done in May 2025, shows a progression of changes. There's an increase in the size of the lesions. So once again, she had global cerebral atrophy, predominant involvement of the white matter in bilateral, occipital, and parietal lobes. And there was also periventricular subcortical involvement with involvement of the U fibers. She had some focal areas of restricted diffusion, which was suggestive of an active lesion. There were areas of contrast enhancement in the left posterior periventricular region and in the cerebellum. The MRI of the lumbar spine showed subtle enhancement in the cauda nerve roots, and both optic nerves had showed mild atrophic changes. CSF was normal, except for a traumatic tap. She had 10 red cells. So considering the previous radiologic diagnosis of leukodystrophy with the parieto-occipital involvement, we considered X-linked adrenoleukodystrophy and Krabs, and because of the periventricular distribution, metachromatic. However, although it's a radiologic diagnosis, we must remember that it's commoner in children, and it's generally progressive rather than an episodic nature as it was in this patient. So that was a red flag, which led us to consider other differentials like demyelination, vascular, neoplasms, and leukoencephalopathy. However, the MRA was normal, which was not in favor of vascular, and the rapid progression of 1 year and the temporal lobes were involved. That wasn't in favor of a CADASIL. The lesions were too symmetric for a lymphoma, and there was no history of any toxin exposure. Even going into the individual leukodystrophy types, she being a female is more likely to present with a myeloneuropathy rather than a leukodystrophy, and enhancement and involvement of subcortical U fibers are not seen typically. Even for Krabs, adult onset is a rare feature and usually is associated with a neuropathy. For metachromatic, they usually have a typical tigroid appearance with extension to the anterior, which wasn't seen in her. So that left us with the demyelination, and out of the 3 MS, MOGAD, and NMOSD, we considered MOGAD because of the bilateral middle cerebellopeduncle involvement. Serology, this was done by immunofluorescence, so the serum MOG IgG was negative, as was the aquaporin 4, and CSF OCB was also negative. However, we have collected another sample of hers, and we even looked into the diagnostic criteria of MOGAD in the continuum. There are 6 phenotypes. However, this leukodystrophy-like phenotype has not been described in the guidelines, although there are some isolated case reports. And the MOG IgG is the cell-based assay is what's recommended rather than the immunofluorescence. So does that exclude MOGAD? The immunofluorescence having a sensitivity of only 45.7% doesn't exclude it. So as a result, we thought treatment delays associated with a poor recovery. So we went ahead with a treatment trial with IV methylprednisolone, oral MMF, IV rituximab, and IV tocilizumab, along with supportive care. After intensive treatment during 1 month in ward, her GCS improved to 15, seizures improved, and her tone normalized with an improvement of power over the upper limbs, 4/5, lower limb, 2/5. Her visual acuity, when assessed, showed hand movements on the right side with 6/60 on the left side. And this is how she first came to us with a seizure, just to recap, and this was her after the treatment. Now she's able to raise her arms a bit, she's saying her name, and she's trying to lift her head. Lower limb power was still weak here. And following that, this was her able to sit with support, and she's able to communicate, able to lift her arms. And here you can see she's able to stand with support, and she's smiling, and her smile explains her recovery. Her EEG also normalized. There's an improvement of the encephalopathy, and the repeat MRI showed a reduction of contrast enhancement and diffusion restriction of the lesions. So the questions for the panel is that, could this be demyelination? We consider demyelination because of the episodic nature, the VEP delay, which would suggest demyelination of optic nerves, the bilateral middle cerebellopeduncle involvement, and contrast enhancement and diffusion restriction of the brain lesions, and the spinal nerve root enhancement. However, the features against it was the symmetry of bilateral lesions. So what would be the key pointers to suspect demyelination in a leukodystrophy appearing MRI? And also, despite the negative serostatus, is the phenotype in favor of MOGAD, like leukodystrophy like MOGAD? How common is it? What are the predisposing factors for some individuals to develop such a phenotype? And experience on treatment options and long-term prognosis, and how long we should continue immunotherapy and monitor remission.
Thank you very much, Joe, for that presentation, excellent presentation. I would like to ask Owen to comment on this case.
Excellently presented, very clear case, very complicated again. You're right that the fixed cell-based assay, which is, it's also a cell-based assay, but it's just a fixed cell versus a live cell, is a bit less sensitive. We have seen this MOGAD leukodystrophy pattern. We can also sometimes see MOG and NMDA coexist, so testing NMDA in the CSF, if that was available, could be another possibility. There's other conditions that can mimic this, I suppose. Mitochondrial disorders can sometimes fluctuate and come and go and mimic a relapsing remitting condition. Biotinidase deficiency is another one that can affect the optic nerve and the spinal cord and look like NMO and can be tested biochemically. So there are a couple of other things, or you could consider genetic testing, but it seems like they're responding to immunotherapy. I don't know if we know why the patients with MOGAD get the leukodystrophy. It might be that they've got some sort of genetic predisposition towards leukodystrophy. There's some consanguinity there in the family, so that could predispose. And maybe if you're a heterozygote for some white matter gene, then you're more at risk. We often see it in children, and we see it after, one or more episodes of ADEM initially, and then we see the leukodystrophy pattern develop. And I think if the immunotherapy is working, it's reasonable to continue that, at least in the medium term for now. Yes, it's rare, the leukodystrophy. I don't know how common. I've seen maybe 3 cases of it amongst we have 500, 600 patients with MOGAD, so it's very rare. So always a bit cautious with that diagnosis. When the antibody is negative, you need to consider other things. I suppose there's also things we've not yet discovered. Yeah, they would be my initial thoughts. Dr. Hartung might have better.
Well, I think the leukodystrophy associated with MOGAD, there have been few cases. I haven't seen one personally. Obviously, we would love to see the live cell-based assay results. Very striking, the effect of immunotherapy, so that would argue against the differential diagnosis of mitochondrial disorder. I would agree with Ian to continue immunotherapy at least for a couple of years, and then reassess. Very interesting case, yeah.
Dr. Fujihara is online, I believe. He could be a good person to ask if he's there. Over to you, Professor.
Can you hear me?
Yeah, we can.
Can you hear me now?
Yeah, we can hear you.
Okay. Okay. Well, as for the leukodystrophy like MOGAD, essentially it has been reported in children younger than 7 years old. So this child was 16, if I remember
16.
correctly.
Yeah,
so
16.
16, yeah.
much older, 16, much older. And the interpretation of why this kind of phenotype occurs in very young children, in my opinion, is that myelin maturation occurs towards 10 years old. So leukodystrophy-like phenotype of MOGAD develops before the myelin maturation is completed. That may be why the lesions are very extensive and bilateral. So in that context, so-called leukodystrophy-like phenotype of MOGAD may not be a likely diagnosis in this particular patient. But as Owen and Peter already mentioned, immunosuppressive therapy seems to be very effective to improve the clinical and the laboratory features. So a certain type of inflammatory condition should be suspected. But if you have any CSF for MOG testing, that may be a choice. But otherwise, I do not have any good idea.
In spite of the improvement, will you do a brain biopsy at Kasu?
Well, maybe not.
Thank you very much.
Thank you.
Thank you, Dr. Sujani, for that brilliant presentation. Next up, I invite Dr. Balasubramaniam Bhavanandan, Senior Registrar in Pediatric Neurology at the National Hospital of Sri Lanka. Over to you.
Good afternoon, audience and respected panelists. I am going to continue with the third and the last case of the case presentation. This a story of a 16-year-old girl. Most of her events occurred during her pediatric age group, so at 6 years of age. So she's an 18-year-old up well until 2013 when she was 6 years. So the onset was around 2013 November. She developed episodes of headache, vomiting, sleepiness, and double vision, suggestive of an encephalopathy, but they didn't seek any medical attention, no treatment taken. And it was an episodic nature, was treated with symptomatic medication. So around 1 year later, she developed behavioral problems for over 1 month, like temper tantrums and sleepiness and insomnia, followed by encephalopathy, and there's focal status epilepticus, and admitted to the hospital. So there are the basic bloods, CSF, viral studies, and ANA APLS screening was negative. And the attack MRI, here you can see there is extensive areas of T2 and flare high signal changes in the cortical wide matter as well as involving the cortex. So she was treated as ADEM with IV methylprednisolone pulse therapy, and she had continued with oral prednisolone for 3 months. So there is a clinical improvement following the initial treatment. So this is the follow-up MRI. So there is there is residual changes, but improvement. Clinically also she's improved. So this is the first episode. It's diagnosed as ADEM. So she was monitored and followed up in the clinic. So she was okay, apart from some behavioral problems. She was treated with in the mental health clinic as well. So in 2015 February, so around 3 months later, she developed another episode with a similar presentation. This time she developed poor vision also on the right side and imbalanced cerebellar signs. So we have done the VEP that shows prolonged latency on the right side. That time we have done NMO antibodies. That MOGAT was not done. It was and the CSF-OCB also negative. So this is the second episode of ADEM. So the multiphasic ADEM was our concern. So started on again managing with the routine immunotherapy with IV methylprednisolone, IV rituximab, and oral prednisolone tail off, and also started on azathioprine. So here we can see the MRI, more or less the same changes, apart from there's a new change appeared in the superior cerebellar peduncle. So she was managed, and 2015 August again she developed a focal status epilepticus, which she was managed with the medication again, and the rituximab also started, and MMF was started as a maintenance therapy. 2015 December again another episode with the similar headache, vomiting, and sleepiness. And here you can see there are some new changes appeared in the right cerebral hemisphere, as well as the pons and the midbrain, and also in the basal ganglia, and as well as the periventricular white matter. So this time also she had the persistent right side prolonged latency. So this episode also treated with immunotherapy, and she was all the time she was had invariable improvement, not complete improvement. So this time you can see the cervical canal, there is cervical cord myolysis up to C5. So there is bilateral intracranial optic nerves are minimally hyperintense in PLA images also noticed. So this according to the radiology report, it could be extensive NMOSD. So the episodes were concluded as cortical encephalitis, as well as the 2016 December episode was the combination of ADEM, optic neuritis, and the short segment myelitis. So she got another episode in 2016 February, the similar symptoms, and there are new lesions in the cerebellum as well as the basal ganglia on the right side. So it also is treated with the similar immunotherapy, as well as this time we tried IV cyclophosphamide also twice, 2 doses. Then following that, she in the next two years, she developed the relapse of the limb weakness on the right side. MRI more or less unchanged. And also 2017 May, she developed severe bilateral optic neuritis. And there is bilateral optic nerve latency was observed, and she was managed with immunotherapy with flex, and also here thought of RRMS and started on weekly beta interferon. So the meantime, we have sent the MOG antibodies and the aquaporin and CSF or CB. They are the and MOG antibody positive with live cell-based assay, strongly positive. Anyway, she developed, apart from the side effects, she had improved clinically. So we have continued the beta interferon for until 2019 March, but later stopped due to severe side effects like fever, vomiting, and headache. So then the next 2 years, she developed the similar type of relapse, worsening of the weakness mainly, and again in 2018 the anti-MOC antibody was strongly positive. But in the MRI changes, there is improvement from the after starting the beta interferon, there is a dramatic improvement in the lesions, but there is progressive cerebral atrophy throughout the next 3 years. So in 2021, she developed a vertebral fracture due to the high-dose steroid we have given, and she underwent a spinal surgery, and she developed remission in 2021. Since then, there's no episodes. Immunotherapy was stopped, and she was on anti-seizure medication and baclofen and Sinemet and vitamin D, calcium supplements for around another 4 years. So this time again, the MOG antibody was tested, that found to be negative, and the aquaporin and CSF OCB was negative. And the follow-up MRI not showing any new lesions, and there is persistent cerebral and cerebral atrophy was noted. So when this child she was presented to us in 2025 February at adult care for continuation transition of adult care. There she developed, she had following complications. She is on carbamazepine for focal epilepsy, steroid side effects, and cognitive impairment. MMSE score is 18. And her EDSS is 5.5. She's having still some impairment in the vision, but it's compared to the acute attacks, it's improved. And she's on IV. Now we are considering to start on IV rituximab and tocilizumab, and also fingolimod, considering this is as a MS. So the recent MRI shows marked cerebral atrophy and cerebral atrophy, and also the spinal cord atrophy. The lesions are still there in the periventricular deep white matter and subcortical white matter. So the examination I have already discussed. So these are the differential diagnoses we considered in this patient. So diagnostic criteria of MOGAD, she had all the clinical manifestations and also a positive MOG antibody. And the optic neuritis wise bilateral involvement was there, which is involvement is there and extensive. And also she had the brain syndrome. But myelitis, he doesn't have a longitudinal extensive myelitis, a short segment cervical myelitis. So if we consider it's a MS, so dissemination in space and the dissemination in time was fulfilling, and she doesn't have any cause apart from the optic neuritis, no other cause criteria of NMOSD. So in our patient, the lesions are more like MOGAD type, but there is, we expect to the lesions to improve with the stereotherapy, but it persists like MS. So in the continuum article, there is some if patients positive with MOGA IgG positivity, there are some red flags for possibility of MS. So we had this patient also has these like ovoid periventricular lesions, and also short segment lesions in the spinal cord, and also development of new asymptomatic lesions over time, and also lack of resolution of lesions in time. So in the questions are like in our patient, this patient is having strong MOG IgG positivity with all the criteria fulfilling, but still having new lesions appear in each relapse, and there is lack of resolution with an immunotherapy. Whether we can consider MS in this patient from the onset, or it is an atypical type of MOGAD, or it's a MOGAD MS overlap.
Thank you very much, Baba.
We can get Dr. Hartung's opinion here too. Complicated case again. I think, how old was the patient at the start when the first?
6 years, sir.
6 years, yeah. So I think it would be suspicious for MOG. You know, there are some studies suggesting that as you go on, the lesions may not continue to resolve as much as they do at the first episode. The oligoclonal bands are negative. That's rare in MS. So, and then it's rare for MS to have, you know, encephalopathy, seizures. So some of those features would favor MOGAD along with the age. So I think there would be a lot in favor of MOG. It's unfortunate this patient has kind of almost developed that leukodystrophy-like appearance and the progressive atrophy. And this is the case, like Dr. Fujihara mentioned, of the younger people that can get that. I've seen it in some older children, but so I would be thinking more along the lines of MOG. There's some suggestion that, and actually this is work from Dr. Fujihara's group, that the attacks kind of wane after about 5 years in MOGAD, and that the attacks can tend to be less over time. So there tends to be a reduction after 5 years in terms of attacks, like we're seeing here. So, but you know, when there's been so much extensive damage, it's hard. There's going to be a lot of lesions everywhere in the white matter. So you're going to have periventricular and juxtacortical, and I just don't. It doesn't really have a flavor of MS. And I'm not really a big fan of the MS MOG overlap, because most of the time they'll have one or the other. And in our region of the world, people test MOG a lot, and they tend to over-test. And when you get a 1% false positive rate, then you can get a lot of cases of MS that have low positive MOG antibodies. So usually in my experience, it's one or the other, and the overlap cases I'm always a bit cautious about. Yeah.
Thank you, sir. Yes, sir.
No, I think I entirely agree with Aaron's assessment. This wouldn't be MS, and again, I think this overlap is some questionable entity. But I think it does underline that contrary to still a widely held opinion, MOGAD is not necessarily benign disease. I mean, you know, I have many colleagues both in Germany, and I remember meeting associated with AAN where they said, oh no, this is, you don't have to embark on heavy immunotherapy early on because it's benign, it resolves, you know. And this is quite amazing, the frequency of the relapses, and yeah. I have a question to Eon and maybe Kazuo. Has, as with NMOSD, a deleterious effect of beta interferon, you know, under the assumption that this is MS been described in Mark?
I don't know. I know it's been described in NMO. Yeah. I think it's more that it's not really effective in MOGAD. I think John Chen at the Mayo Clinic did a study and looked at all the different medications, and it just looked like the MS medications were not effective. But I don't know that making them worse, but maybe there are other studies. Kazuo can comment there.
Can't hear you.
We can, yeah.
Can you hear me now?
Yeah.
Oh, okay. I have nothing to add. And in our retrospective analysis of the MOGAD patients who had been treated with interferon beta 3 treatment was not able to reduce the risk of relapse. That's our own experience. And so again, like the leukodystrophy-like phenotype, it develops in a very young age children. So in patients with leukodystrophy-like phenotype of MOGAD, the behavioral changes may persist and seizure may persist. So as Peter already mentioned, not all MOGAD cases pursue a good prognosis, and some of them may have a relatively severe disability for a long time. So, but as for the coexistence of MOGAD and MS, I echo Owen, and while slightly positive MOGA IgG may be detected in a fraction of MS patients, but in this particular patient, it was strongly positive, and I don't think it's likely to be MS. That's my view.
Thank you, sir.
Thank you very much. Thanks.
Thank you, speakers, and our esteemed panel for your valuable contributions.